morning, Renu.
Good morning, Declan. How are you?
Very well, I'm very excited.
I can imagine. Look at all this merchandise you've got on the table.
Yes, do you know what this is, this ball?
It looks like a football to me.
It's a kind of a football. If you're watching this on YouTube, does anyone know what this is? It's a Gilbert ball. That'll be a clue for people who know their stuff. And on the front of it, there's a logo for the Wallabies and the British and Irish Lions. And there's a jersey here on the desk in front of us as well. It's a very red-looking jersey with this particular crest. It's got 4 nations on it, and
So are we doing a podcast about the rugby? Is that what we're doing today?
Yeah, it's kind of. Well, look, it's a lion themed podcast. Is that terrible? We have a great guest in the studio.
We have an expert brought in for the occasion.
whose name happens to be Dr. Alex Lyon, a cardiologist from London. Alex Lyon, welcome to the podcast.
Morning, Declan. Morning, Renu. It's great to be here in Melbourne.
I think he's excited. He's got a little flash of red.
He's
got a red Lions jersey on.
Yeah, very good.
So look, welcome to the podcast. I am quite giddy and excited because as we record this morning, it's Saturday morning. It's the second test of the British and Irish Lions rugby tour to Australia, which is an extraordinary event. Alex is going to tell us about it in a few minutes. It only happens every 12 years or so. And this is a rugby ball and that's a rugby jersey. And we're tonight going to the MCG to watch the second test, me and Alex. So.
See, I think cricket when you say MCG and second test.
You
but
think test.
No, this is.
And that's actually quite a lot of Melburnians. Yeah. Rugby's not the first sport around here, Alex. We'll get right into that. But let me introduce the podcast properly, I suppose. Today, it's actually a topic we haven't done on the podcast before, Renu.
No, and we've done a lot of podcasts on hormonal therapy in prostate cancer. Yep. Urologists have been prescribing ADT for a long time now. We're really pushing for urologists to prescribe ARPI, so doublet therapy. But we do need to focus also on the toxicity of these drugs and especially the cardiotoxicity. So I'm hoping to learn a lot. In this podcast.
That's what we're going to talk about. It's a specialty field called cardio-oncology, which didn't exist, I don't know, Alex will tell us, not that long ago. And now it's a full-blown subspecialty in cardiology and oncology, the field of cardio-oncology. And it's definitely important for very many of our audience who look after patients with advanced prostate cancer who are prescribing ADT and who are prescribing AR pathway inhibitors. And that they're the two kind of areas we're going to focus on. So we're going to focus on patients with advanced prostate cancer who are being started on ADT. How do you screen? How do we screen?
Stratify. Yep.
Because these guys do have, a lot of them have cardiac issues, don't
Absolutely.
they?
Yeah.
And then baseline, and then what's the impact of starting ADT, different types of ADT,
drug interactions,
drug interactions, and then especially the second therapy area, ARPIs, the AR pathway inhibitors, because again that flows into cardio-oncology. Matters that Alex will talk to us about, drug interactions. So that's what we're going to get through today. And today's podcast is supported by our silver partners, Cipla Pharmaceuticals, who've been supporting us for a number of years now. And they have the license for Degarelix, one of our ADT therapies that we use here in Australia and is used all around the world.
Great support from Cipla. So thank you.
So should we go and talk to Dr. Lyon now?
Dr. Lyon, this is your first Lions
the rugby
tour.
ball. He's
You've got the talking ball.
Yeah. So, Alex, you're a cardiologist at the Royal Brompton in London.
Yes.
And you've been involved at the start from this whole cardio-oncology thing. So before we dive into the specifics of prostate cancer, can you just tell us, what is cardio-oncology and where did it all come about? And I know, reading your profile, you've been involved in the ESC, the European Society of Cardiology, their inaugural guidelines, for example, on this topic. So tell us a bit about cardio-oncology and why it matters.
Yeah, well, I think if we start with the big picture, what do people in Western society die of? They die of cardiovascular disease or cancer.
Yeah.
And actually, if you look at both fields over the last 30 years, they've made amazing advances. And if I look at oncology, you've made amazing advances now. People used to die of metastatic cancer. Now they get cured or they're living with their cancer controlled as a chronic disease. So now well over 50% of people who are diagnosed with cancer would expect to be alive 10 years later. Whereas in the 1970s, 80s, 90s, that wasn't the case. But what we're now seeing is that the treatments that are curing cancer or switching cancer to become a chronic disease are accelerating cardiovascular disease. Mm. So now we have a challenge because we're keeping people alive just for them to get out of the frying pan of cancer into the fire of cardiac disease. But a unique aspect of this is we know when they're coming to your clinics and being given treatments that are curing cancer but can cause heart disease. I don't know when someone's going to have a heart attack or get myocarditis, but I do know when they're going into an oncology clinic or a hospital to get prescribed a treatment that could cause heart problems. So the concept of cardio-oncology is to say, why don't we get the people who might be at risk before they start these treatments and do something to impact so that we can get the win-win of having their cancer treatment safely.
Makes sense.
Great summary. It really is,
Yeah.
isn't it? And we can see these clinics are now popping up in cancer centres like ours here in Melbourne. We have a team of cardiologists, cardio-oncologists who work in big cardiology units in the main hospitals, but in the cancer centre have developed these services.
Yeah. And actually, you guys know cancer is common. 1 in 2 adults are going to get told they have a cancer in their life. And now we've seen that 1 in 3 FDA licensed cancer drugs have got a cardiac or circulatory complication. So this is a tsunami that we're now seeing in cardiology of this world of oncology patients where either the cancer itself is driving a problem that could affect their heart health, or in the majority, it's about the drugs. And I think bringing this to prostate cancer, what is prostate cancer? It's a disease mainly of elderly men. And what do elderly men have? They have a lot of cardiovascular disease. And for many men, and I think this is true in the UK, I'm sure it's true in Australia, they don't get their background health managed effectively. The first time they get to a doctor is because they've got a problem passing urine, or they've got blood in their urine. And then they get a diagnosis of prostate cancer, and it's the first time they had a proper interaction with the medical system. And that's the opportunity to actually say, well, we've got to really have an impact on this person's whole health. Let's deal with the prostate cancer, get their symptoms better, get their prognosis better, but let's use this as an opportunity to educate them about their cholesterol, their blood pressure, do they have diabetes? And then start to think about how do we treat them effectively for their prostate cancer in the context that some of the prostate cancer drugs, great at controlling prostate cancer, can accelerate their cardiac disease.
So that's a really important point, Alex, because when patients are already linked in with a cardiologist and then they have a diagnosis of prostate cancer, I feel that that's managed a lot better. But it's those patients who've only ever seen their GP. And then all of a sudden they're seeing a urologist for their prostate cancer. They've probably got some undiagnosed underlying cardiovascular disease or even risk factors that are just not identified until it's too late. So how do we risk stratify these patients? What should the urologist do?
Yeah, I think the way I think of this is that every man who's diagnosed with prostate cancer and is going to start androgen deprivation therapy should be having a risk score, a cardiovascular risk assessment. Now, that should be being done to every man over the age of 50 anyway.
Yeah.
So the question is, has it happened? But in cardiology terms, we divide patients into those who've already got established disease. So if you've got a man who's come to your clinic and he's already had a bypass or he's already had a carotid endarterectomy, you don't need to do a risk score because he's got the disease, or he's had angina, he's had stents. You've got the patients who've already got it. They're the highest risk. But for many men, they've never had a cardiovascular problem yet, and so it's then about a risk score. Now, we're not asking urologists and prostate cancer oncologists to do this. It's about signposting the patient to their GP, because family physicians, they're the experts. Because then if the risk is elevated, the question we always think is, why? Is it the diabetes? Is it smoking? Is it blood pressure? Is it a combination? And then what can we do to control that, to mitigate the risk? And as you know, statins, blood pressure medication, and now we've got a tsunami of effective diabetes drugs which don't just treat diabetes but are good for our cardiovascular health. The SGLT2 inhibitors, half the world are injecting themselves with GLP-1 agonists, and we know that those are really good for the vascular health. So there's lots of tools which we can use now to help men's cardiovascular health and risk. And to get that at the beginning of their prostate cancer journey will just help as they pass through, whether it's to make sure they're fit for their general anesthetic for surgery, but also as they then go into medical therapies for prostate cancer. because, as you know, those are now giving an amazing prognosis to a lot of men with metastatic or locally advanced prostate cancer that previously may not have lived for 10 years, but they're now alive 10, 15, 20 years. Well, what's going to kill them if it's not prostate cancer? It's going to be cardiovascular.
Yeah, I mean, metastatic disease is more and more becoming a chronic disease. So, and combine that with the cardiovascular chronic nature of it, it's a double hit. Alex, there are those patients that have, the obvious modifiable risk factors. They walk into your clinic and they're overweight, they're diabetic, they're hypertensive, and that's an easy identification. But there are also those non-modifiable risk factors like their genetics or their, the fact that they're men in
and
itself.
Age.
And age, exactly. So it is important to have some kind of a risk assessment tool because those are the people who could have non-diagnosed disease.
Yeah, so in medicine, not specific to cancer patients, there are lots of established 10-year cardiovascular risk scores. So anyone, whether male or female, over the age of 50 should be seeing their GP and getting their 10-year risk score done. And in Australia, there's the AUS-CVD score, which GPs, cardiologists, general physicians across Australia will be just doing this routinely. So the concept is when you're diagnosed with prostate cancer, somebody, probably the GP, should do the AUS-CVD risk score. Or if you're in the UK, it's called a Q risk score. And around the world, every country's got its established scores. And those scores essentially give you a risk that's low, less than 10%, 10-year risk of an MI or a stroke, intermediate, 10 to 20%, or high, more than 20%. And certainly everybody in the intermediate and the high risk should be having the factors that are driving that risk addressed. And as you say, some we can't change, but there are many we can. And a very simple low-hanging fruit is, are they on a statin? Yes or no? And if they're not, they probably should be. There was a really interesting study based out of Sweden where they scanned 25,000 people over the age of 50 with a CT coronary angiogram. And these are just people, never had any history of heart disease. And the overall incidence of just having coronary disease in this population was 42%. So 42% of people have coronary disease.
Wow.
And then if you add drugs that accelerate coronary disease, it's like petrol on the fire. And the most typical are the 3-monthly GnRH agonists. Wow. So we know that they are accelerating the disease in people who are already there, that got it. And that's now going to be 42% of your population, and maybe more once you start to get to over the age of 70. That Swedish study was 50 to 70-year-olds. So imagine all the 80-year-olds.
Absolutely. Wow.
Yeah, it's and so these risk scores, just to chuck examples out at you, if you've got a 70-year-old man in the clinic and he has been stented in the past, so this is probably his score somewhere, and he's on a statin, is he already into like intermediate risk or something? Even if it's controlled?
So these scores are for people who've never had the stents, never had symptomatic cardiovascular disease. So this is the well woman population. Once you've got someone who's already had it, and so we have our success, our survivorship story in cardiac disease is myocardial infarction. So in the 1960s, 25% of people died of a heart attack if they went into hospital with a heart attack. Now it's less than 2%. So people are surviving their heart attacks in their midlife to live to get cancer in later life and come to your prostate clinic, having had their MI, had their bypass, had their stents. They'll be on treatments. Some are well treated and are still very effectively managed, but lots over time things drift. So the man who's already had a heart attack or stroke in his history, they're the highest risk.
Okay.
But these 10-year risk scores are for the people who've never had a problem.
So I think that already means renewed, that there's a whole chunk of patients, because a lot of patients come in because it's in Australia, very good advanced, health system here. They will have had their cardiovascular disease treated. They will be on a statin and they might have had a stent. And they might be they're out playing golf, but already in our minds, we should be thinking, we're about to start this poor guy on ADT. We should understand that he is at a higher baseline risk than if he did not have well-treated cardiovascular. Is that fair enough to say? Let alone the one who probably does need the baseline screening of, no, I've never, I've only gone to my doctor because of my back pain. Yeah. And he may have other undiagnosed things. But the message is we who prescribe ADT need to be much better tuned into these baseline risks before we Right, that's
Yeah.
right.
And so for the man who's already got an established history, simple question would be, when did you last have your cholesterol? You're on a statin. When did you last have your cholesterol checked? And some might go, 3 months ago. It's perfectly controlled. Excellent. But for many, it's, I haven't checked it for years. You know, my heart attack was 15 years ago. I'm just on this medicine, and they're just out there living life. So it's also about how we tune and get things optimized. And then the key message, and this is back to cardio-oncology, is when you then start someone on an ADT therapy, particularly GnRH agonists, then over time their risk factors get worse. So you might recognize the common story of men on these sort of Zoladex or Leuprolin, which is they put on fat, they put on bad weight, and they lose muscle strength. So over time, that gives them an increased risk of diabetes. So there's somewhere between a 20 to 25% increased risk of new diabetes in men on 3-monthly ADT therapy. And then if you've got coronary disease, this is all petrol on the fire. And then it accelerates it. And you see the men who have their myocardial infarcts or present with angina in the first 6 to 9 months of starting GnRH agonist therapy because it's accelerating the problem. And then you've got the second group, the ones you're keeping alive, where it's more like 10 years of treatment and exposure, long-term exposure, and then it's new disease that's being sort of progressing. So what we want is not just to check their blood pressure and their cholesterol and their HbA1c at the beginning, but actually every 6 months. So in our guideline, if you've got men who are going to be on GnRH agonists, they should be getting those risk factors reassessed by their GP. And really, probably the role of the urologist and the oncologist is just to signpost them, to remind them when they're coming to your clinic, you're just checking how they're doing, you're looking at the PSA, discussing their latest scans, is it responding? You want to also be just saying, hey, have you been to your GP to get your cholesterol rechecked or your blood sugar rechecked? Are you exercising? Stop smoking if you're still smoking. Those things.
And it's an opportunity to positively modify their risk and improve their overall lifestyle, isn't it? Just to kind of draw attention to these things that they may never have thought about.
Absolutely. And we know that a lot of the risk factors for cancer and the risk factors for cardiovascular disease are the same.
Yeah.
So, and we know that the lifestyle approaches are going to help both.
Yeah. And we say that all the time, Declan, to patients, because, when they're coming up for prostate surgery or they've been diagnosed with prostate cancer, they always ask, should I be on a special diet? And we always say, you should be on a heart-healthy diet. Happy heart is happy prostate. So we do sort of say that, but I do think it's important to focus on these specific risks.
I'm looking at this paper that Axel Mercerberger and Nathan Larenchuk and some colleagues wrote in the World Journal of Urology last year.
Familiar names there.
We'll put a link in the show notes, but the title is Cardiovascular Disease Risk Assessment and Multidisciplinary Care in Prostate Cancer Treatment with ADT, recommendations from an expert network. So apart from things like the ESC guidelines, and we can link to them in the show notes.
Yes, absolutely.
The prostate cancer community are beginning to provide us with information and tools, and this one's got a bunch of risk stratification type graphs and tables and so on in it, and which are quite useful. But I think it's not a burden in the clinic to be there. You're about to start a patient on ADT. You've explained the diagnosis, but to take the time, it only takes a minute or two to figure out, is this a patient who already he has been treated coronary artery disease, and Alex has just told us that's already a red flag, or he's the sort of guy perhaps needs a bit of workup because we're about to write this thing that is going to significantly change their risk. And Alex, if I recall correctly, because we all know that when you start a patient on ADT, LHRH analogs in particular, we want to ask you about the difference between the agonist and the antagonist.
Yes. Yeah.
But I recall it's a lot of the mechanism is plaque disruption. I think so those patients who especially have underlying coronary artery disease, atherosclerosis, it's within that next year or so. So it's not like cumulative. It's not the second instance you told us. It's like they've got baseline disease and they're at risk of plaque disruption. So you really need to optimize their risk factors before you start this. Plus then the other one of, okay, they're going to develop a bit of metabolic syndrome type thing due to the ADT. So I'm hearing that message. Anything else you want to add on that? Because we want to talk about agonists and antagonists as well.
Yeah. Well, it's also the segue into that, isn't it? So when you start someone on a GnRH agonist that they have the potential for a flare. Now that flare is complex at a biological level, but part of it is inflammatory. So you've got to think that as well as inflammation being a risk factor for cancer, inflammation is a risk factor for coronary disease. And in fact, the plaque rupture, you get the build-up of the cholesterol, but the event that triggers the heart attack is when the fibrous cap, which is separating the blood from the cholesterol plaque, it's when that splits and ruptures, and then the clot forms. And that process is an inflammatory process. So we know that if people have a pneumonia or other inflammatory diseases, chronic autoimmune inflammatory diseases, that accelerates their vascular risk and the event rates of heart attacks and strokes from carotid disease. And we see that with GnRH agonists through this flare. So the men who are sort of got a lot of plaque burden, they're at the highest risk of having an event in that first 6 months, 9 months, because they get the inflammatory flare, plus then there's the effects on the lipids and the glucose metabolism. So you may know this, but GnRH agonists, they increase your LDL cholesterol, they increase your risk of type 2 diabetes, and that's all the sort of perfect ingredients for heart attacks, isn't it? Yeah. So that's why we've got to be managing these risk factors.
And then the difference then between the agonists and the antagonists, because many of us will selectively use the antagonist, like degarelix. We've traditionally used it for the high burden metastatic disease because it's very rapid suppression. There's no flare, zero flare from a cancer point of view, as well as that important point of it is attractive to us. But then we understand that those patients they're on ADT. They're going to have the risks of developing metabolic type syndrome. But the acute events, is it different between the analogs and the antagonists?
Yes, it is. So this started in the laboratory. So a number of preclinical models, mice prone to vascular disease that have been studied for years in the cardiac laboratories. And if you treat them with GnRH agonists, the vascular disease accelerates. If you treat them with a GnRH antagonist, it doesn't accelerate. So there was clearly some biological difference. And part of it is this inflammatory drive. But then it's also about the lipids, the glucose, the fat metabolism, what you've referred to as metabolic syndrome. We all sort of think we know what it is, but it's complex. But all of that seems to be driven by the agonists. But what's fascinating is that the antagonists do not drive this process. So then we go to the clinical data. And it started with degarelix, and there's lots of excellent observational studies showing that there's less cardiac events in men who are treated with degarelix versus the other GnRH agonists. There was a study called PRONOUNCE, which was a randomized controlled trial to try and answer the question. PRONOUNCE, unfortunately, was one of those trials that got caught up in COVID, and as a result, it has struggled with recruitment in that first couple of years of the COVID pandemic, and as a result was underpowered. But what was fascinating about PRONOUNCE that teaches us something is that in that trial, every patient had to see a cardiologist at baseline before they started their agonist or antagonist. And as a result, the event rate, even in the agonist arm, was much lower because they got everything optimized. Lesson, whereas that doesn't happen in the real world, does it? And to be honest, cardiologists can't see everybody with prostate cancer. And then we had the new oral GnRH antagonist, Religulix, and there was the HERO trial. So you might remember this was in the New England Journal of Medicine, and not only did it show that it had a superiority in terms of treating the prostate cancer, but they had a pre-specified secondary endpoint of cardiovascular events, and there was a significant reduction in compared to leuprolide. And then you put all these trials together in a meta-analysis, and what we see is that now for GnRH antagonists, they have between a 48 to 52% reduced cardiac event rate compared to agonists. So coming back to your patients, the man who's highest risk, the one who's already had an MI, he's had a bypass, he's had stents, he's had carotid surgery or peripheral vascular disease, or his 10-year risk calculator says he's in the highest risk group, they should be getting GnRH antagonists.
Very clear message.
Very good message.
I'm learning it. It's very good.
Absolutely.
We wanted then in the final segment talk a bit about the ARPs, the AR pathway inhibitors, these superamides that are now. I mean, they've made a huge difference, haven't they, Renu, for survival? And we've got a number of them to choose from. Yeah. We've apalutamide, enzalutamide, darolutamide, and we still have abiraterone in the background. But like nowadays, in very many countries, all these patients starting ADT will be starting one of these drugs. So questions we would have are, well, how does that, so it's the same time, they're starting within a few months or at the same time. How does that RP choice come in on top of the ADT, number one? And number two, tips and tricks, because the RPs, it gets more complex for us urologists. There are drug-drug interactions, especially with blood thinners and statins, for example. There are tools out there that can help us choose. But in real-world practice, maybe you'll share with us some wisdom about choosing, managing, how do we say it, addressing DDIs, drug-drug interactions for these patients.
I mean, firstly, does adding an RP increase the risk significantly?
So yes, is the black and white answer to that. Wow. So if you look across the different trials, and I'm thinking more the second generation RPs, that what we see is a very strong signal of hypertension. And when I think of this as a cardiologist, there's two flavors of hypertension. There's the person who's already got high blood pressure, but then they go on to an RP and it disrupts the blood pressure control, and the blood pressure now is no longer controlled. And the second is new hypertension. You've never had high blood pressure till you put on the drug, and now you develop it. So the simple and important take-home message to your patients is monitor your blood pressure. So again, in our guideline, we say anyone who's starting these cancer drugs that can cause new high blood pressure need to get a home blood pressure monitor. And it's not just going to the doctors and getting it done, because this needs to be done at home. And then there's an education piece that GPs can do on how you actually do that. You need to rest for 5 minutes. You don't just run in, rush down and put on the cup. But ultimately, monitor your blood pressure. And this is a good way of them also thinking about their whole cardiovascular health, isn't it? Once you start to say, check your blood pressure, it's getting them to think about healthy living. Yeah. But if you look across the RP trials, the rates of new high blood pressure are in the order of 20 to 25%. That's a lot of people if you're treating. And then there's a second issue, which is other cardiovascular events. Now, that's maybe because they're developing new high blood pressure and they've already got that coronary disease, and it's the next sort of straw that broke the camel's back of the event, or it could be that these drugs are doing other metabolic factors as well. But there is definitely also an underlying increased risk of MI, heart failure, arrhythmias like atrial fibrillation on top of the hypertension. So it's not just hypertension. And then if you think of abiraterone, its rates of hypertension in Latitude trial were about 37%. Wow. That's 1 in 3. So whether you're going for an RP or abiraterone, and I look at the efficacy data, and these drugs work. So, it's not saying don't use them. It's just let's use them safely by educating patients. They've got to monitor their blood pressure. And then from that, we can then use the right drugs to protect them. Because this is in my world, but we've got blood pressure drugs that are great at treating blood pressure, but have no benefit on your heart or blood vessel health. Things like amlodipine, thiazide diuretics. But we've got loads of blood pressure drugs that are also good for your heart. ACE inhibitors, angiotensin receptor blockers, the sartans, spironolactone's good for heart muscle. And of course, there may be an interesting interaction of spironolactone with prostate cancer because of its anti-androgen effects. So there's different logical things we can do that also not just manage their blood pressure, but help their overall cardiac health. But the take-home message to you is when you're starting to prescribe someone on one of these RPs, tell the patient they've got to start monitoring their blood pressure. And the best place to do that is in your clinic. So you can maybe get one of your urology nurses to check their blood pressure before they start, and then it starts to educate the patient, hey, blood pressure here is an important factor for this treatment.
I noticed, Renu, he's not saying at any point along this to refer them to the cardio-oncology clinic. So that's very important as well. You couldn't cope with all this. This is a big, this is general practice really here, general oncology practice, general urology practice. We need to be addressing it. And you reserve the cardio-oncology clinic, I suppose, for the highest risk patients, or the ones who've got some specific toxicity. It's complex now; they've developed a cardiac event, etc. But we have to be working much closer with primary care on all this, don't we? And with the patients themselves and nurse practitioners, etc. But it strikes me that primary care are probably the key one, because often it's not practical to be back physically in the clinic 2 weeks later. Lots of patients have machines themselves, I find as well. Actually, to quite pick one up in the pharmacy, etc. But we've got to we as the prescribers have to be totally tuned into this, don't we?
Exactly. And You took the words out of my mouth. Cardio-oncology services cannot see every cancer patient. We just get drowned in it. So what we need to do is see the right ones. The highest risk patient, you'll have men who'll say, well, yeah, I'm getting a bit of chest pain. And it's happened just in the first few weeks after starting ADT therapy or one of your ARPs, and we need to get on top of it, not to stop the cancer therapy, but to ensure that they have the right choices. I spend a lot of my time saying to my oncology and urology colleagues, look, they're on a GnRH agonist. This is a case we need to switch to the antagonist. Which of the ARPs should we use? Which are the blood pressure profiles? And then, as you said, drug-drug interactions.
Let's talk about that.
And this is complex. Yeah. I'd first of all signpost your listeners to our ESC guideline, because we've got a data supplement on the webpage, and it's open access, which has all the common cardiac drugs and all the cancer drugs and the particular drug-drug interactions. Because this is complex pharmacology, you need to have specific sort of assessments on a drug-by-drug basis. But if you want an easy take-home, for statins, generally rosuvastatin does not have many interactions, whereas simvastatin and atorvastatin do. So when I'm thinking which statin shall I choose, usually it's rosuvastatin, and it's one of the best. So it's just, that's a simple take-home. Once you start to get into DOACs, anticoagulants, gets a bit more complex. And I'd really say to your listeners, go to a trusted source, whether it's our guideline supplement or another clinical pharmacology web page where they've got it and they've validated which ones are the choices are the safest. And I suppose it's another sort of reminder that if you've got a patient who's already on some of these cardiac drugs and you're about to start an ARPI or ADT therapy, they must be high risk. Why are they on a statin? Yes. Why are they on a DOAC? That means they must be already an elevated risk.
You don't need to plug it into some calculator. You know it already.
Yeah. Yeah, taking all this on board, what we don't want people to do is listen to this podcast and go, it's all too hard. Yeah. It's too hard to prescribe these drugs. I'm not going to do it. I think the point that Alex has made is really important. Our job is to identify risk. It might influence your choice of treatment. And we should be signposts, really. We should be using the resources at our disposal to say, well, you need to be managed by your GP, or you are the person that perhaps does need to see a cardiologist.
Yeah, and it's an interesting world, isn't it? We're all doctors. We've all become super specialists in our fields, but we've also got to think of the patient as a whole, the holistic approach. And if you're not going to die of cancer, you're probably going to die of heart disease. And I actually educate my cardiology colleagues, if you're not going to die of heart disease, probably going to die of cancer. So just to sort of give you a real thought experiment, there's a new field now called reverse cardio-oncology, which is if you look at people with established heart disease, they have a higher risk of new cancers compared to people who don't. So now we're looking at why cardiovascular disease itself is a driver of cancer. And maybe all the world of cardiologists should be saying, right, you survived your MI, you're a man, let's now do 6 monthly PSA screening because you are now in a higher risk group for future cancers. And there's both preclinical model data, there's epidemiology data. So I think we're all trying to think about what we can do best for our patients and looking at them as a whole.
What a cracking podcast. I really enjoyed that.
I've learned a lot. And I thought this was all going to be about the Lions.
Well, yeah. Well, can we come back to that to finish? I want to get his predictions for what's going to happen at the MCG tonight. But this is the first cardiologist we've had in this studio in our 5 years of doing GeCast. And I sense that this needs to be a kind of a regular thing. We need to work closer with our cardiology colleagues. And who better than Dr. Alex Lyon on the day of the second Lions test here in Melbourne to be educating us. Alex, thanks so much for popping in, taking time out on a Saturday morning.
Well, it's great to be back in Australia. I was in junior doctor in Sydney in 2000, 2001. That was 24 years ago. And 24, of course, means that it was a Lions tour back then, 2001. That was my first taster. And as you said, the Lions only come to Australia once every 12 years. So it's a real special occasion, isn't it, for the world of sport? And you can just feel the excitement.
So this is your third?
This is my third tour because I came back.
Because he came back 12 years ago.
In 2013 as well. So, it's special. And I'm married to a lovely Australian lady from Melbourne.
Yes.
So actually with the family, we come back to Australia quite frequently. But it's always good to catch up with medical colleagues here, the people I worked with back in 2000, my new sort of medical colleagues through the world of cardio-oncology, and then, catch up with my family.
Oh, amazing.
How wonderful. Well, thank you so much. And so finally now, so as we speak here, the Lions are 1-0 up.
Yep.
Having really beaten the Wallabies quite convincingly last weekend. I'll ask your opinion as well, Renu, in a second.
God.
Tune in, don't tune out.
Okay.
And but what's going to happen tonight? There's much discussion. There's some big Wallabies coming back into the side. Lots of discussion about a very physical performance coming from the Wallabies. There'll be 90,000+ people at the MCG. It's going to break the world record for attendance, I think. Yeah, what's your prediction?
It's a cauldron, isn't it?
Yes.
So, Declan, that's a great question. I think the heart wants it to be a really close match. Yep. Because I think that will, be best entertainment. As you say, the Wallabies have strengthened their team, and we hope that will lead to a bit more of a competition. But the brain says the Lions is too strong. And I think they got a bit wounded by the second half, because the first half they were really on top. Second half last week, they really dropped the ball of really punishing the Wallabies. And I think they're going to come out really hard, and it's going to be a strong performance. So I predict quite a big win, maybe by 20 points.
Oh, there he goes. By Lions by 20. What do you think, Renu? Pat Cummins to win the toss and bat first?
You said a whole lot of words there that I'm struggling to follow. But if you get me a nice jersey, then I'll root for the Lions.
There you go. All right, give me back that rugby ball. It's time to wrap up this podcast. Thanks very much to Alex Lyon for coming and joining us here. And thanks very much to our friends at Cipla for supporting us at GUcast and for supporting this team podcast today. I hope you enjoyed it, and we'll be back soon again.